Hello, and welcome to NGR 7769. My name is Dr. Derek Limp. This is the first of many Video Everywhere feedbacks for Week 1 discussion. I've enjoyed watching each and every one of your Video Everywhere. I know it was a technical challenge for many of you, but everyone did a fantastic job. I feel like that I have a name and a face to go with, and I'm going to enjoy working with each and every one of you as we journey through patient safety and quality improvement. Again, week 1 was basically an introductory to the course, being able to navigate the syllabus as well as Blackboard, and as well as the different assignments and discussion boards that were due. Starting this next week, week 2, you will be utilizing your error reduction book by Patricia Spaeth, and you'll be answering the questions at the back of the book. What's unique about the discussion board, they will be due on Thursday, the initial response, followed by a feedback by at least 2 of your classmates by Sunday. Now, many of you will see that you will not be able to access the discussion board initially until you post your response to the question and the video. This week 2 does have a video with some questions to answer corresponding to that. So week 1 was really an introduction on tell me your story, and then kind of overview of some crucial points that we'll be covering along with the book this semester. So hopefully you have gotten your interest piqued about patient safety and quality improvement. Let's go into week 1 feedback in terms of the presentation. I hope you enjoyed the 3 presentations that were presented to you, and the syllabus, the excellent presentation done by Poor Communication by Dr. Ruth Thomas, in which she played on Lewis Blackman's story, in which the major concern was that this was a systematic error as well as a human error, in which the poor communication led to the death of Lewis Blackman. And I'm sure it saddened you like it saddened me in terms of, the parents brought Lewis in for elective surgery and end up losing his life, and I'm sure they would gladly have taken that back. But you see that the lapses that occurred in terms of him getting insufficient fluids, the wrong medication, the lack of communication between the nurses and the physician because of they didn't want to disturb them. This is a crucial issue in terms of patient safety that we need to address and talk about. And hopefully we'll have some robust discussions on how we can prevent this from occurring. Can humans really multitask? And simply, we know the answer is no. It's very difficult for us to focus on one task wholeheartedly at one time. So, we can't multitask effectively, and that is the misnomer and the misconception that many humans have, or people have, that they can multitask when in fact they cannot. The moral of the story, the force, and this is a unique story in which clear communication, proper communication can save somebody's life. It simply was, the different scenario that went on with the different animals that presented to the bear, when all they had to do is communicate clearly, and it could save their life. So, the opportunity to close the loop on communication is always appropriate. There were several National Patient Safety Goals in 2015. Some of them, I just asked you to identify 2, but identify patient correctly, improve staff communication, use medication safety, prevent infections, identify patient safety risks, and prevent medical mistakes in surgery. So these are some issues that I hope you can utilize for your patient safety initiative project, as well as the folder in which you saw previous patient safety initiative projects. And those, as we'll talk in the coming weeks, the assignment will be due on March the first, but in terms of the title or your topic will be done February 1st. So hopefully we are all thinking about that. In the patient safety journey, which I presented in the syllabus, what is normalized deviance? Normalized deviance is exactly what it said, that we've been breaking the standard for so long that it becomes accepted. And we can see in healthcare how this could be a grave problem in causing medical mistakes and causing your peers or the organization to continue to do the wrong thing, and which could lead to extreme illnesses or mistakes within patients. So we have to stop that mentality of normalized deviance. And we have to, hopefully, as quality improvement and patient safety new advocates, that when we see this happening, we have to call it out and to make sure that it does not occur. Atul Gandhi, the book he penned in 2007 was Better: A Surgeon's Notes on Performance. Atul Gandhi has become a very a trailblazer in terms of medical mistakes and patient safety in the World Health Organization, in terms of how medicine can improve. And the following week, I think week 3, we actually have a Atul Gandhi TED discussion. So yeah, hopefully you will start to read some of his books and start to see some things that he's trying to do, like in Checklist Manifesto. These are books that create opportunities that we as humans can prevent us from having mistakes. Captain Sully, in his flight rescue, or his heroic act he did, quite frankly, he had that disbelief. And oftentimes in medicine, we have that disbelief, meaning that I didn't think it can happen to me. And when we need to realize and have that mentality that, yes, it could happen to me at any time. So we have to have a systematic preventive, patient safety preventive attitude at all times. Incivility. This is a huge issue in terms of healthcare, how we have become incivil to people. We've become incivil to people at times, and that we cannot have an incivil way of dealing with healthcare, and that creates lapses and barriers in terms of our communication with our colleagues and our team in healthcare, and we cannot have that. QC competencies, there's basically 6 QC competencies: patient family-centered care, teamwork and collaboration, safety, evidence-based practice, quality improvement, and informatics. And we will touch on each of these issues throughout the semester. The acronym HUDDLE, this HUDDLE has a severe interest to me in terms of my research interests. I've published several papers on the huddle moments, but this is simply healthcare utilizing deliberate discussion linking events. And quite frankly, it means that no one can hide in the huddle, that if us as interprofessional teammates can come together, speak about our patient, come to a collaborative agreement, then we can prevent mistakes from occurring, whether it be pharmacy, the surgeon, anesthesia. It's always an opportunity that we can communicate effectively within that. Annie's story, mistakes the nurse made. A major mistake that the nurse made was in terms of looking at the machine. Oftentimes we think the machine, can this be right? Just such as the Lewis Blackman case. They took the blood pressure 12 to 15 times. They just couldn't believe it. They could not believe it. So we have those human errors that occur. But more importantly, a systematic problem. The systematic problem was the blood sugar machine had been wrong, and it had been, the other people had seen that and noticed that. But it wasn't until, the initial response was to put the nurse in suspension, But then the root cause analysis, they looked at it. This is a systematic problem. And as you'll see this semester, that most mistakes are systematic processes, are systematic mistakes. In other words, that nurse suffered a second victim effect. And oftentimes what will happen is that second victim, the first victim is the patient, the second victim is the healthcare provider, and there's a third victim, which is the organization in which the incident occurred. So understanding the dynamics of the victim response will help us as quality improvement advocates and patient safety advocates, that we can prevent that from occurring. And more importantly, the culture in any story change. Leadership plays a crucial part in the safety and the culture of an organization. As you're well aware, if the leader does not advocate for safety, then you're going to have that normalized deviance. And quite frankly, that Annie story, the whole cultural change, it changed from a shame, blame, second victim effect to, hey, this is a system problem. How can we improve this process? How can we prevent this from occurring? So as we begin our patient safety journey for week 1, I hope that you have found the discussions robust and informative. Please, if you have any questions in terms of the course, please feel free to email me. Many of you have. It's dglimp@gmail.com, and I look forward to your week 2 discussion. Thank you.